Along with the movement kind of not working so well, as most MSA patients know, there's also swallowing and speaking difficulties that generally tends to be progressive. So we're going to give you all those good information and tips from our last formal speaker of the day. And when she's finished, I'll have some housekeeping. Just don't forget, we have patient caregiver breakout sessions also. Now, I've taken enough of Marisa's time. Merisa, Palovcak. Close. You know, I got to go to language school or something.
But boy, oh boy, do I have a job ahead of me following Joellen and being the last speaker of the day and worrying about my posture as I stand here because she spent the whole time talking about that. But I will be here today talking about speech and swallowing changes with MSA. I'm going to start with speech, and please write questions down that you would want answered in the question and answer session at the end so we can address it then. So common speech changes that we see with MSA, and the type of changes that we see will vary with this different subtype of MSA, MSAP, MSA, with the ataxia. But typically we do see hoarseness in the voice, frogginess, people saying they can't project their voice, they have lower volume, they may be more monotone and difficulty with inflection. From a speech perspective, sometimes people say difficulty articulating sounds, mumbling, slurring, sounding like they've been drinking when they haven't had an alcoholic beverage in a while. We do see stuttering that would start not related to anything as a child. So if you were a childhood stutterer and continue to stutter as an adult, that would not be related to MSA. But if you were never a stutterer and you start to notice that there are these hesitations and pauses and repetitions in your speech, that would be something from the disease. And reduced facial expressions, which can really affect nonverbal communication. And they say nonverbal communication is 80% communication, so that can be a very big change that people see. I'll probably talk more about it later. But I had one gentleman say to me one time, I'm laughing on the inside, but nobody else knows about it on the outside. And so we work very closely with people to make sure that they are kind of doing some of these over-exaggerated facial expressions as well. So when people come to my office, typically what the caregivers will say is I'm constantly asking them to repeat themselves. It's getting frustrating to talk to them. Their speech is getting worse when they're tired, and they get annoyed with me when I ask them to repeat themselves. And then I look at the patient, and they say, my spouse is losing their hearing. They need to get their hearing tested. I'm always loud enough. I was always a quiet person. I hear that probably 99% of the time. People will say, I never was a loud person. I always was more soft-spoken. They say, I can hear myself, so I don't know why others can't hear me. It's so frustrating to keep repeating myself, and the one that I hate to hear people say is I've become an active listener. I like to listen in conversation, and I hate to hear people say that they're withdrawing from social communications like that. So then I tell my patients, I don't know about your spouse's hearing, but I've gotten mine checked recently, so I know it's normal. And if you have something to say, we want to hear it, so we're going to make it better. A lot of times, doctors do this all the time, patients do it all the time. They use the terms interchangeably. So they'll come to me and they'll say, I'm having difficulty with my voice, and they may really mean their speech. And they may say, I'm having difficulty with my speech, and they mean their voice. So I always like to clarify this because it does help the therapist a lot if you can become more familiar with the terms. So voice is the sound that's produced when the air from the lungs causes your vocal cords to vibrate. So your vocal cords are sitting kind of right here in the middle of in your neck. And when you're using them, you'll feel the vibration of your vocal cords in your neck. So you can produce a high-pitched sound and a low-pitched sound. And then speech is the way that we actually shape those vibrations, those sounds, by moving the muscles of our tongue, our lips, our soft palate to make a meaningful sound. So for normal voicing, when we're talking about just the vocal cords, like I said, they sit above your trachea. And in order to produce sound, they come together and they vibrate together. They have to vibrate at the same time. And if there's ever a change in that, one's vibrating at a different time, they're not coming together fully, it's like dancing the tango with somebody that doesn't have rhythm or has two left feet. It's just not going to work. So that's when we get those changes in the voice. Depending on the flexibility of the vocal cords, there'll be a high pitch down and a low pitch down. Much like a rubber band. You want to stretch it out to get a high pitch sound. You want to contract it to get a low pitch sound. Going along with this, earlier we've heard it twice about this inhalation stridor, these respiratory changes, that sound that we can hear. We always would want to get somebody looked at, an ear, nose, and throat doctor. I'm going to move over here because I feel like I'm only getting one wheel. We want you to get looked at by an ENT. Because if your vocal cords are not opening and closing effectively, that could be causing the stridor. Typically, what we may find is that the vocal cords are not fully opening, so that everybody's sitting here, nobody's talking to me, so your vocal cords are open right now, and the air is just coming in and out from your lungs and going out of your mouth or out of your nose. And as we start to talk, they come together. The concern with that stridor is that they come together and they don't fully open. If they don't fully open, we don't want to lose an airway. So that is certainly something we want to take a look into. So there's some norms here. For a male, normally we would say in a normal conversational setting, we would want their loudness level to be between 72 and 76 decibels. For a female, a little bit lower, about 70 to 74. Another thing that we also know is nobody has a perfectly pitched voice. So if we were to measure, well, they've done studies to see, if we were to measure the amount of time there's a hoarseness in our voice or a pitch change or something in our voice that's not a normal, beautiful pitch, we would say about 5% of the time that we do that, there's going to be a hoarseness. Anything above 5% would be considered a change in normal voicing. So what we typically find with Parkinson's disease or MSA is that there may become bowing of the vocal cords. So earlier I kind of talked about how the vocal cords come together. So they kind of go like this and they vibrate like this. When we have the ability to look at the vocal cords of people with MSA that are having vocal cord weakness, we find that they bow. So they come together and they're like this. And so there's kind of like, there becomes a hole in the system, and that does change the quality of the voice because there's more air that can then escape through that bowing of the vocal cord rather than it being straight. The other thing that we can find is that when they get bowing, they lose their flexibility because remember I said you want to stretch them out to get a high-pitched voice and you want to contract them to get a low-pitched voice. Well, if they're starting in this position and they have to stretch like this, that's much less flexibility needed. But if they're like this and we need a high-pitched voice, there's much more movement that needs to happen. And so that's why people lose their vocal flexibility and can get that monotone quality of the speech where I like to use the example of that guy, Ben Stein, who does those Visine commercials. He's got that perfect monopitched, monotone voice. Typical findings with MSA, again, could depend on the subtype and the severity, but we typically find that when we measure the vocal volumes of patients, they're in the 60s. Between 60 and 67, I have seen people in the 50s. So you can imagine what that would sound like if you were in a noisy restaurant and only talking at about 58 decibels. The other thing that we see is reduced range of motion with speech. So typically, we don't see muscle weakness with these kind of diseases. It's not a neurological disease like ALS or Lou Gehrig's disease that would cause muscle weakness. But it could be reduced range of motion of the muscles that's affecting the way that you're using them. So if I were to test the muscle strength of people's tongues and lips, my typical findings are that they're still strong, but what's happening is they're not moving their mouth as big as when they're talking, similar to kind of the smaller steps that we might see with the P subcategory of MSA. And so pretty much what their speech sounds like is this, and they're barely moving their voice when they talk, and this is why they have so much trouble being understood, because they're not moving anything. But if I get bigger and louder, everything gets better. So that's one of the things that we work on in speech therapy. Again, the monotone speech, difficulty with inflection, we want you to get your vocal cords looked at to see if there is any of that bowing going on that could be causing that reduced inflection and the monotony of the voice. The reduced facial expressions and eye blinking, and rapid rate of speech with difficulty coordinating breathing and talking. So your lungs are your powerhouse for your voice. You need to be able to coordinate turning your voice on and breathing at the same time. And if coordination is an issue, specifically with the cerebellar subtype of this disease, where you don't have the ability to coordinate breathing and talking, that's where you can get into a lot of trouble with the rate of speech. So how do we fix this? A lot of people may or may not have heard of the Lee Silverman Voice Treatment Program. My disclaimer to this is that this was developed strictly for Parkinson's patients, and there is very little literature on its effects of MSA, but the exercises that they do with this program are very beneficial to be used for the MSA population. So the Lee Silverman Voice Treatment Program, or the LSVT program, was developed to retrain your brain so that your speech is more clear through the use of 2 words. Think loud. So I talked earlier about how your volume drops. Why does your volume drop? Because your ability to perceive how you're using your voice during conversation is off. So Joellen talked a little bit about how your posture can change. A lot of times people, a question I ask everybody when they come in is, what were your initial symptoms? What did you notice to send you to a neurologist? And a lot of times people will say to me, I didn't notice anything, but my spouse would say to me, why are you hunched over like that? Or hurry up, you're moving slower than you used to. Or why are you talking so low? And one of the things that we now know through researching this is that people, their ability to perceive what their body's doing at that point in time is impaired. But if we were to videotape somebody walking and show them, play it back, they can see what the changes with their body. And we know that with their voice. So when they're talking at 60 decibels and they think, well, gosh, why isn't anybody, they must not be listening to me. I'm talking loud enough. But if I were to record their voice and play it back, which I do every session, they can then hear what their voice sounds like. They can then hear that they are not, in fact, loud enough. And the purpose of this LSVT program is to retrain the way your body you're using your voice, and to retrain the way your brain's making you think your body's doing things. So you have to retrain your vocal cords, you have to strengthen them. So this program uses intensive voice exercises. It focuses on increasing oral range of motion through bigger movements of the mouth to improve point of articulation, improves intonation, improves breath support, and improves overall intelligibility, or what percentage of the time the listener is understanding what you're saying. So a little bit more just about the LSVT program quickly. Again, it is technically only used in the Parkinson's population at this point in time, but I certainly use it for the MSA population, and there's other populations that are currently being studied in using this, and I have seen positive effects of this program. The one negative of this program that I would say, if you want to call it a negative, is that you have to go 4 times a week for 4 weeks. So it's 16 sessions total, and they like it to be, it should ideally be consecutive 4 times a week for 4 weeks. So you have to devote at least a month of your time to go to therapy. They are individual sessions, and the sessions last between 45 to 50 minutes each time. When they studied this program, which they've studied many, many, many times on the Parkinson's population, they found that the effects of it could last for up to 2 years after treatment. So as long as you continue to do the home exercise program when you finish, you should see carryover of it for a very long time. Other compensatory strategies that we recommend: slow down and over-articulate. One of the things that we know, especially with the ataxia or the cerebellar subtype, is that there's difficulty with coordination. So if you can look at how quickly my mouth and tongue and lips are moving right now to make these sounds as accurately as they need to be, when you have difficulty with coordination, that's where you get some of those changes in your speech production or the slurring. So I say to people, slow down and try to say every sound in the word. It's going to feel very awkward for you, but it's going to improve overall communication between yourself and the listener. And that is the ultimate goal. Whenever we cannot have a communication breakdown, It doesn't matter what we have to do to get to that point. That's what we need to do. Lessen the amount of words per breath, especially if you tend to find that you run out of breath when you're talking. One of the things that we know is that sometimes people do what we call talking on residual air. So when we breathe in and out, we don't always exhale all of the air in our lungs, otherwise our lungs would collapse. So there's residual air in our lungs. So if I don't take a breath now where I feel like I kind of need to take a breath and I still keep going, I'm going faster and faster because I'm running out of air and I'm getting out of breath when I'm talking. Something we see a lot with this patient. So I will say, if it's only 2 to 3 words per breath, that's what you're going to do. Remember, our overall goal is communication effectiveness. The last, and this is my biggest thing that I love to tell people, tell your communication partner how you would like them to respond to you when you are not understood. That is the elephant in the room, especially for unfamiliar people to you. People don't know how to respond when you're having difficulty. They don't know whether to finish your sentence for you. They don't know whether to have them order for you at a restaurant. They don't know if they ask you to keep saying, what, is that going to frustrate you? So you need to lay it out there. You need to become comfortable with how you want people to deal with when they're not understanding you. It may be that you say to your caregiver, your spouse, your significant other, you know what, take the pressure off of me and order this for me tonight. I'm having trouble with the waiter. Or it may be that you say, no, give me the time to say, it might take me a little bit longer, but give me the time to say what I want. The other thing I will say to the communication partners, sometimes with MSA, as people get more fatigued and their muscles are more tired, it's harder to do the things that specifically to talk. And as we're going through this, we're going to talk about swallowing. Remember, the same muscles they're talking with are the same muscles they're eating with. And so these muscles, they're using them all day long. So we expect a bit of fatigue to happen as the day goes on. One of the worst things you can do when you don't understand somebody is to say, what? And then they say it again. And again you say, what? And then they say it again. And now you're frustrated, they're frustrated, and how many times people will say to me, I just say, forget it, it didn't matter what I wanted to say. We don't want that to happen. 9 times out of 10, when you didn't understand what they said, you understood something they said. But you might have missed one word or two. And we all have a tendency to say, what? Huh? And then they repeat that whole sentence again. So what you would want to do to limit your frustration and their frustration is to say, I heard you said this, but I didn't hear what you said after that. Or I heard you said you wanted something for dinner, but I wasn't sure what it was that you said you wanted. Then they only have to say that 1 or 2 word that you missed. So you're saving your energy, they're saving their energy, and communication breakdown has been now repaired. There's also options for augmentative communication. So a lot of times people may be resistant to this because they still want to be able to talk. And we say to people, that's what we want you to do. Your first thing we want you to do is to be able to talk. When that is not as effective, when you've used all those compensatory strategies that we talked about last time, thinking loud, over-articulating, big movements, and that still is not effective, we need to be able to augment our speech. So there's writing, carrying a pad and paper around with you. This right here is something called a Boogie board that's made by Brookstone. And it's kind of like a whiteboard, but it's black. And you just push that button and it erases it. It has the stylus that attaches to it, so you would never have to worry about where's the pen. And it's really light, really small. Letter boards as well. Over here is an example of a letter board. And the way that would work is you would have somebody, if somebody could point, one way that you can use this letter board is they would just spell out what they wanted to say. If somebody's having dexterity issues with their hands and their arms and they're not able to actually point, the way this letter board is set up is that you could actually put numbers here. This would be 1, 2, 3, 4, 5. Now again, this is not going to be fast, but this is an effective way to communicate. You would say to the person, is the letter you want in first row? They would say yes or no. Second row. So if they say yes, is it E? No. Is it F? F. Okay. Second letter. first row, second row. You go through that way. A lot of times you don't have to spell the whole thing. You just need 1 or 2 letters, and then you've got what they want to say. The other thing, and the most important thing for everybody in this room to do, is to establish a functional yes-no communication system, so that if all else fails and you have nothing else available, you at least have a reliable yes-no system. If it's a head nod, if it's thumbs up, thumbs down, if it's eye blink once for yes, twice for no. Eye blinks I'm not totally crazy with, because blinking is a natural thing that happens anyway, but if you make it a deliberate yes, no, that's your eye blink. Or look over here for yes, look over here for no. So you have them turn their head one way, turn their head another way. Once you have that functional communication system established, you should never have communication breakdown again, because you can always then go to a simple letter board like this and go through the columns that way. Other boards you can make your own. Take pictures of things in your house, create binders, or create big posters, pictures of just bathroom needs, food needs, toileting needs, anything that you would need to do to get creative, we discuss. The other options are higher tech things. There are devices out there that you could purchase through the insurance company where you would type what you want to say and it would speak it for you. And if you lose your ability to type, there's other access methods that can be assessed by a speech-language pathologist and/or an assistive technologist. But with the advent of iPads and other technology, we're finding that there's apps that you can download for free or for $1.99 that are doing the same thing as these $7,000, $8,000 pieces of equipment that are out there. In your handouts today, I attached a list of apps that are out there that you could purchase. Now, I have to tell you, this probably changes daily. There are tons of things that are being developed every day, and there's no way that I could actually capture everything that's out there. There is in that list iPad and Kindle Fire devices as well, apps for those. Also in your handouts are, if you have a laptop, there's also free software you can download to your laptop that would do the exact same thing. You type what you want to say and it speaks it for you. So those for PC and Mac as well are listed in the paperwork. So now I'm going to talk about swallowing changes. So you may or may not hear the word dysphagia. No, what the heck does that mean? It simply is just the medical term for difficulty swallowing. And if there's ever changes to the movements of your muscles of your mouth or your throat, this can cause any kind of changes in your swallowing. So I'm going to quickly talk about, and generally talk about, the 3 stages of swallowing. The first stage is the oral stage here. So this is when the bolus, or the food that you're going to eat, is getting ready to be prepared to go down into your throat. So food's brought into your mouth, we roll it up into a ball, we transfer it back. This incidentally is the only stage of swallowing that we have control over. The other 2 stages that I'm going to mention next are not in our control. They are strictly reflexive stages of swallowing. So once the food, this is like the bolus here, once this is transferred and reaches a certain point in our mouth, and again, this point in our mouth will change as we get older. Babies tend to have it higher up, and as we get older, that reflex kicks in lower down. But in any event, when that food hits that certain point and causes a reflex to trigger, that reflex is in place to protect your airway. Because what we're going to see is we want the food to go down this little piece back here. All of this here, that's your airway. That's where we don't want it to go. If it goes there, it's going right into your lungs. If it goes into your lungs, that's when we worry about what we call aspiration. So once the food travels down, it goes into your pharynx or your throat stage. And this is where the muscles of your neck will elevate your voice box to kind of get it out of the way. So if we think about right here, this is where our voice box is. Again, we want the food to go back down here. So you'll see there's this piece of tissue right here. It's called the epiglottis, this right here. What happens when we swallow is this piece of tissue comes over this opening here. It closes off that gap. The other thing that happens is your vocal cords come together. They squeeze really, really tight. And the third thing that happens is your voice box, this whole thing, lifts up and moves forward. And that moving forward motion pulls this epiglottis over the airway. So you've got 3 protective mechanisms in place to protect your airway. That's another reason why keeping your voice is really important. Keeping it strong is really important. If they're not closing and they're bowing, and something starts to go awry, and that food starts to go down here, this is your first line of defense. If these are completely closed, it pushes it back out. And if your vocal cords are weak, it's going to squeeze right past them and into the lungs. So another reason why doing your speech exercises and keeping your voice nice and strong is very, very important. So you've got these 3 protective mechanisms in place to keep the food from going down the wrong way and into your esophagus. The muscles along the back wall of your throat here, the muscles along here, are what propel the food down through the throat. And then the last stage is when the bolus, or the food, enters from the sphincter here down into the esophagus. Typically, this is not something that we see a problem with MSA, an esophageal stage. If you're having problems with this stage, which we'll talk about what the symptoms of that would be, it typically may be related to other things not related to MSA. So symptoms and signs of oral or pharyngeal throat stage dysphagia: slowness or fatigue with eating. Your jaw gets tired with chewing. You have difficulty moving food around in your mouth. Things are getting stuck. Pocketing of food. You go to swallow and you still notice that something's stuck on the sides of your mouth or behind your teeth. You have to use your finger to get it out, when before you used to use your tongue to clear it out. Coughing or choking with eating or drinking. A wet or gurgly voice after or during eating. Feeling of food sticking in your throat. Feeling like you need to swallow a couple of times to get the food down, or even pills down. Pills are a big problem people have. They say pills constantly feel like they're getting stuck in their mouth or their throat. If you're having any of these symptoms, this is what you need to tell your doctor right away, so you can get a swallowing evaluation done and somebody can assess what's happening with your swallowing. Signs and symptoms of esophageal stage: sensation of pressure in the chest, chronic heartburn, feeling like food sticking in your chest, pain with swallowing, belching, and sore throat. Going back to the signs of oral stage dysphagia, let me tell you typically what I see with MSA. Pills, big problem. I'll tell you why that's a problem. You need a lot of coordination to be able to get a pill down and a liquid. So you put the pill in your mouth, you take a sip of liquid. You've got to get the pill and the liquid together, and it's got to all go down together. But what we know with MSA is, number one, movement's slower, so your muscles are moving slower. Your coordination will be off, and liquids move faster than the pill. So the liquid goes down and the pill stays, and that's when you get the feeling that the pill's sticking in your throat. So what I usually tell people to do, most times people say, well, I cut the pill in half. Never a great idea. The pills are shaped that way for a specific reason, and when you cut it in half, specifically like those longer ones, like the calcium pills people do, it makes it a jagged edge and actually makes it harder to swallow. So before you go ahead and you cut it, the first thing I would say to do is try to take it with something a little bit thicker, because something thicker is going to move slower and allow you the time to coordinate getting everything together. Best thing you might want to try is something like pudding, yogurt, or applesauce. Take the spoon, put the pill in there. Now you've eliminated one step of the process. Everything's all together at once. You're taking it with something thicker so that if it moves down, it's going to more likely to move together and not stick as much. If that's not working, then you obviously would want to try a speech-language pathologist to see if there's other methods that we can come up with before we tell you to crush meds, because sometimes meds just can't be crushed, and then we have to figure out other ways to get them down. Typically, people will say to me, 2 ends of the spectrum. I'm having trouble with solids, or I'm having trouble with liquids. Liquids we know to be a problem because coordination, remember everything I talked about with that reflex triggering. Once that reflex triggers and your voice box lifts up and the epiglottis flips over and your vocal cords come together, that is a very coordinated action that needs to happen. It's like all the stars need to be aligned up the right way for that to go right. And if one thing is out of whack, you're going to have trouble. And we know that liquids move faster. If I was to take a cup of applesauce and a cup of water and pour it on the table, what's the first thing I want to clean up is the water, because that's going to go everywhere. The applesauce is going to stay more contained. Well, that's what we know is happening when you swallow liquids. You're pouring it on the flat surface of your tongue. And if your tongue's not moving fast enough or not coordinated enough, it's not going to be able to keep it in your mouth. So sometimes thicker things are easier because you can control it better and you give your body the time to coordinate all of those swallowing mechanisms that need to be in place. So, other symptoms of dysphagia: unexplained, unintentional weight loss. That becomes a problem. I am not a nutritionist, but I work very closely with nutritionists at Penn. And when people are having an unintentional weight loss with a disease where we need your muscles to work, we get a little bit concerned, because when you're losing weight, you're not just going to be breaking down your fat stores, you may also be breaking down muscle stores for energy. So we want to make sure that you're at least using what you're eating as energy and not from within. So if you're having an unintentional weight loss, and I'll tell you where that comes from a swallowing perspective. Portion sizes get smaller. Why do portion sizes get smaller? Meals are taking longer. When meals take longer, two things people say to me: I hate being the last person done, so I say I'm finished when I still might want to continue to eat. Or, because you're eating slower, your brain catches up to your stomach, and you realize that you don't need to eat as much, and so you're not eating as much, you're not getting as many calories in. And if physically you're having difficulty, that can also cause that unintentional weight loss. Changes in dietary habits. Before people even know they're having swallowing troubles, they'll start to slowly make changes. So they'll say, oh, I stopped eating lettuce. So that's always a red flag to me. When you stop eating something that you used to eat before, that's a red flag that goes up right there. I will tell you typical things that do cause people trouble from a swallowing solids perspective: anything that has small parts like peanuts, popcorn, granola. Any leafy lettuces can stick to the back wall of the throat, so that can cause more difficulty. So people will start to avoid things that are causing them trouble. What happens with that? That can affect constipation as well, because we might slowly start to drink less because we find that we're coughing more than we drink, and coughing's not very comfortable, and so we drink less. That can cause a whole bunch of more problems with constipation. Recurrent pneumonias, particularly in the right lung, we would be concerned of what we call an aspiration pneumonia. So when food or liquid does go down the wrong pipe, it's going into the lungs. And if it goes into the lungs and we're not able to cough it out, we can get pneumonias that start to form there, and that becomes a concern for us. Fevers of unexplained origin, runny nose, watery eyes with eating, and sneezing during eating or drinking. Big thing that we know. Most times people will know, we all know when something goes down the wrong way, right? We start coughing, our face gets red. We know where our body's trying to get it out. One of the things we know with MSA is as people start to chronically aspirate or chronically have things go into their lungs, your body will desensitize itself to the aspiration event. So what would be a normal coughing reflex to try to get it out, your body desensitizes it to that. So you may not always cough to know that something's going the wrong way. So you have to absolutely look for these other signs here. This runny nose, watery eyes with eating, sneezing. Your body's going to try to do whatever it can to try to get it out of your lung. So sneezing is another abdominal thrust that will do that. So most times people think, oh, I have allergies, or it's this time of year. If every time you eat or drink something, your nose is running, your eyes are watering, or you're sneezing, big sign that you may be aspirating and that you need to get an evaluation soon. Strategies that we recommend: postural changes. You probably will read about doing something like a chin tuck or a head turn to one side. I will not make recommendations on that without doing an evaluation first, because we do know that some of those changes that people may give you could cause problems if we don't know why it's happening. So I see this a lot sometimes when I go into the hospital. People say, oh, put your chin down, you're choking, put your chin down. We need to know why you're choking, because if you put your chin down, you're changing the anatomy, and that can actually make swallowing worse. So there are postural changes that we can do, but also diet modification, thickening your liquids, using softer foods, adding gravies and sauces to things to keep them moist and more cohesive. Verbal cues. Sometimes people hold food in their mouth. They can't initiate that swallowing. Joellen talked earlier about freezing. When you just can't get a movement started. That can happen with your swallowing. You get food in your mouth and you want to transfer it back, you want to swallow it, but your body's not doing it. So sometimes you need to give yourself external cues, verbal cues, to go ahead and get a swallow. Something as simple as, in your head, you can just say it, 1, 2, 3, swallow, and that can just trigger a swallow to happen. There are options for alternative sources of nutrition, something like feeding tubes that would go into the stomach. And any of these strategies should only be implemented if they've been recommended by a licensed SLP once you've had a swallowing evaluation done. And that is it for me. So I think we're going to do question and answer.
Thank you very much, Merisa. We just heard 3 powerful sessions, and we still have the Q&A to come, so don't anybody move yet.